Hello, everyone. Thank you for allowing me to speak for the Stroke Inspire program. I'm Dr. Jennifaye V. Brown, a physical therapist, and this presentation is the courage to speak. What was said about the AFO, which is an ankle foot orthosis, and I want the focus to be on fit for better functioning for you. So I have to tell you some things. I am the owner of a business, JVB Physical Therapy Services LLC, and I do get book royalties from Brace Yourself, everything you need to know about AFOs after stroke. This information that I'm going to be presenting is not to be taken as medical advice. So please consult your physical therapist, your occupational therapist, orthotist, or physician based on any changes you may want to make to your AFO based on what you heard today. Thank you for that. So I have to give you some definitions and then some disclaimers. As with research, after a period of years, you have to destroy everything so that the pictures you see of the AFOs, and you will not see any images of people who were in the actual research study. If you do see AFO pictures, those are from my personal collection that I have made for individuals. And we're going to use some abbreviations. So I tend to use individuals with stroke because I think we need to put the individual first and the stroke second. CVA is for cerebral vascular accident. Again, AFO is for ankle foot orthosis. It's a leg brace for your foot, ankle, and leg. PTs, physical therapists, OTs, occupational therapists, and HCPs, healthcare providers. So what's the objective of this short presentation today? I wanted to explain to you the research study purpose and its significance, and then provide topics related to AFOs based on my research, my book, and my clinical experience. So who am I? I am a PhD trained neurologic physical therapist. My PhD is in exercise science. I have been board certified for 4 10-year terms by the American Physical Therapy Association in neurology. That's my specialty. I'm also a certified aging in place specialist. Why? Because a lot of individuals who had had their stroke or other neurologic disease processes that I treated could not stay in their homes. And I think they deserve to be in their homes. So I would do a home evaluation and say, change this, do this. And they were allowed to live in their home. And not only that, about 90% of the people that I made a custom AFO for, they were able to walk better in their homes without falls. People say I'm a stroke rehab sage, and I think that's because I just continue to study my craft daily. And then I really love physical activity and exercise because for the long term, I think that's the best thing to do for stroke post health fitness. And then my research was on the perspectives of individuals with stroke regarding their AFOs, how they fit, how they were made, how they are functioning for them, and how they function in them. And then stroke health disparities. Um, I am at risk for stroke because I have sickle cell disease. I've had joint replacement, a reconstructed knee because they said I was too young to get a knee replacement. So I understand what it takes to live a life of healthiness for the best health outcomes for me, and which is to eventually prevent a stroke from happening. So it's an icebreaker. I wanted you to just take a look at this picture. This is someone's heel in an AFO, and this AFO tends to be hinged. You can see that on the side. It makes it much wider. Notice that their heel, though, is touching on the inside, on the left side, the inside of that heel. And then on the outside of that picture, you see a brown liner. but there's a big gap in space. All right. And I thought, isn't it odd that the heel is this narrow, but they're wearing an AFO that's this wide, and they have to get a wider shoe to accommodate that AFO. So did the person buy two pair of shoes? Did they buy a size shoe that's smaller and narrower to fit their other foot? Because if they wore this large shoe on the other foot, they would be at a risk for falls. And this is one of the main reasons why I changed my scope of practice, how I decided to make AFOs for individuals with foot drop because their foot is dropping and they need to raise the foot up. But I wanted the AFO to fit them and not just fit their foot, but also accommodate the shoes that they wore and fit for function in the activities in which they like to engage. So my research was about getting the opinions of individuals with stroke regarding how does the AFO impact their walking and their foot weakness. Remember, their foot is dropped after stroke and we have to bring it up so they don't trip and fall. And sometimes the brace will prevent the foot from getting stronger because it's rigid. The leg can't move and the foot can't move. And I wanted to change that. And then I asked, how does the AFO make you feel? Like an object because you're wearing one? Or does the AFO serve as a conduit, as a way for you to get out, be engaged, and be a part of social activities? So I had people take pictures of their AFOs, then of them wearing their AFOs, and then a video of them doing something meaningful to them in the AFO. Then I asked them some questions. And from those questions, 6 major themes evolved. The first one is that the AFO impacts their ability to choose what they want to wear and the type of shoes that they have to wear. Everyone was told that they have to wear a sneaker a half size larger and then wider to accommodate the brace. But then I started treating women who don't even own a pair of sneakers. And they were wearing their nice dress shoes, casual flats. A lot of women just don't engage in exercise and activity. And so they wore normal, just regular walking shoes. And so people also said that if I wanted to wear a dress, the sneakers wouldn't go with the dress. Most of the men didn't worry about it at all because their AFO was covered by long pants. The second thing was the AFO characteristics. They said it was rigid, stiff, big, bulky, and heavy. But when I took the actual AFO and put it on a scale, it probably weighed less than a half a jar of a small can or tub of peanut butter. And the perception that it was heavy was because their leg was weak and the physical therapist was not teaching the proper mechanics of gait or to improve the mechanics of gait, which is just to walking, that gait is walking, to bend their knee, how to slide their leg forward without really leaning to the other side or hiking up their pelvis in order to lift the leg, which was weak. So not that the brace was heavy. And yes, the brace had to be rigid and stiff in certain areas. But when it came time for me making my specialty type of braces, I made sure it was rigid where it had to be, but flexible in other places to accommodate the foot. Another theme was AFO modifications and maintenance. A lot of these AFOs get heated up, they add a pad, but when you do that, you often make the brace wider. And then when you put it in the shoe, it changes the shape of the shoe. I tell a lot of people to get a shoe with a deep toe box if possible, so that their toes can move in that area and still have room for the brace. But when you make the brace wider, it flattens out the shoe, and then their toes were touching the top of the shoe. Another thing I see with AFOs is that they put two straps right across the front of the ankle. Well, the muscle that helps to lift your foot comes right at the front of the ankle on the inside. And if you put a strap there, you depress it. It won't be able to contract and lift up if it has the potential. So I take all of my straps and I put them on the outside of the brace and move them to the inside of the brace. And that helps to flatten out the foot so your leg can come forward. In most of the conventional braces that are made now, the leg cannot come forward because people aren't strong enough to move it forward, or they use a rigid Velcro strap that goes through a metal loop and comes across the other side. And it prevents the leg from moving forward. So, one thing I changed based on how weak person was, I used different tension straps that allows the leg to come forward. And if your leg was really weak, you had a stiffer strap. If it was stronger, you got a strap that had a lot of give in it. The fourth theme was self perceptions. So, what do you think about yourself when you look at a picture of you with the AFO or the video of you doing something? In the comments where it's uncomfortable, it's sad that I have to wear this in order to walk. But then I said, well, what do you think other people think of you? They look at you funny. It draws attention. And what we really want people to see is you, the person, not the brace in and of itself. And again, that's why I wanted to change the way braces are being made. And then another thing was communication. The people in the study said they really didn't have much to say about it. And they were told the typical shoes that they would have to wear, that it wouldn't fit. The typical shoes that they just wear every day, it probably wouldn't fit in the brace. And then I thought, we need to make the brace to fit in the typical shoes that they wear. And last, I said, if you had to tell anybody about your whole process of getting the brace and wearing the brace, what would you want to change? What would you recommend? And they said it has to be a shared decision making process about how this brace is going to be made so that it can fit, so that I can function in it. So, shared decision making, work as a team, right? And then their opinions about their shoes that they wear, their clothes that they wear, and what they like to do needs to be valued and appreciated by healthcare providers. So let's answer study question one, the AFO impact on stroke recovery. Was it good for walking? Was it good for improving the strength of the foot and leg? Well, the first thing that people said, it benefits, it provides stability. I can walk because my foot's not hanging down, my ankle is stable. But then it became a barrier to performing certain activities, and it prevented the return of movement in my foot and ankle. So the AFO is stiff and it can be rigid, all right? And so if it's stiff and rigid, you have to move differently at your pelvis or your hip. You have to swing your leg out to the side. You have to hike your hip to get it forward, all right? If you're going downstairs, you can't bend your knee. It won't allow your knee to come forward. So the second option is, well, we can make it a hinged AFO or we can decrease the stiffness in the AFO. But the research shows that if you make a hinge or you decrease the stiffness in the AFO, it does not increase the ankle strength. And so I would like to tell all of you all who wear an AFO, if you want to improve your ankle strength, go to your therapist and ask them to loosen the strap so that you can slide 3 fingers in there and practice doing activities where your knee has to come forward, backwards, and move side to side. It's really easy. You can squat, you can scoot in a chair forward and backwards, and you can scoot side to side. You can sidestep in a squat position. You can practice getting up and down from the floor. Now, getting up and down from the floor, you may have to really loosen that strap, or you just get a spandex strap. So look how far forward my leg could come forward if I had a spandex strap. Another thing they said about the AFO is that it's also a psychosocial barrier. You can't choose the clothes and the type of shoes that you want to wear. You have to wear what the brace fits. And then there was this sense of abnormality about the AFO. So if you're sitting and you want both of your feet to be flat on the floor, well, you can't do that with an AFO that's shaped like this. One foot would be up in the air and the other one would be flat. So, question number 2, how does it make you feel? So, we already know it provides stability, so it's good for walking, but then it's often stiff and it doesn't allow the strength of the leg to return, or the foot and the ankle muscle strength to return. So, how does that all contribute to the brace itself as an object, or how does it make you feel in terms of being engaged? Well, people can sense when their foot is moving better or not, when it's in the brace or when it's outside of the brace. And that self-esteem, that self-awareness is linked to body esteem, what you feel and what you understand and know about your body and how it's changing. When you knew that your body was getting better and you could do different things, you became more independent. You took more risk. You did more things. But even if you had this sense of awareness that you're not getting better, but you were taught how to do something and compensate and feel safe doing that thing, you took more risk. So when you're self aware, you can be more independent. All right. And then that improves your ability to engage. All right. You don't feel like an object. You feel that you can do something with the object. Another theme that came about is stroke recovery. People feel that they can't do anything unless they recover. Well, what does recover mean? People think they want to return to normal. But if you look at your brain and you have a stroke lesion, the area is black, that brain tissue is dead, and the nerves that control your leg or foot comes through that area, they're dead too. So they're not going to come back. So essentially, you can't be normal. If you had 100 of those motor neurons and 75 were damaged by the stroke, 25 statistically cannot do the work of 75. So therefore, you won't be quote unquote normal. But that doesn't mean you can't participate in your daily living skills and do things that bring you joy. You may just have to do them differently. Okay. So we have to reframe what we think of as stroke recovery. It really depends on the lesion itself, the location of that lesion, how large that lesion is, and then how severe, meaning the time without oxygen that caused the deficit in the brain area. So they said after a long period of time, if I have to wear this AFO, it's just going to be a sign that I'm not getting better. So they became ambivalent. They began to resent the AFO. But you have to flip it. If you wear the AFO and it's made properly so that you can fit in it and function in it, look good in it, and feel good in it, the long term is you'll be able to walk better. And walking better is good for your health, your heart health, and your brain health. And not only can you walk better, you can engage in things in the community and feel safe to do so with that brace. But again, wearing the AFO meant not normal despite being able to walk. So when you look at the outcome of my research and it's supported by other research, there's a mismatch. People value strength gains more because if their foot and leg got stronger, they wouldn't have to wear the brace. So they value the strength gains more because they don't have to wear the brace versus having to wear the brace and being able to walk. But for your health outcome, being able to walk and walk briskly at a higher intensity is much better for you in the long term in terms of your health outcome. It's good for your heart health and good for your brain health. So, what really matters? And this was communication between the individual with stroke, their caregiver, and with healthcare providers. And this is what they want to know. Will I walk again? And will my strength come back? So I really think we as healthcare providers have to discuss and be realistic about stroke recovery. And as those changes occur, can we modify the AFO to accommodate the different aspects of improvement? All right. And that needs to be a shared decision making process. We need to listen to what folks are saying about their AFOs and what they are actually doing. The research shows that perspectives of individuals with stroke are not considered during the process of getting an AFO, using an AFO, improving the AFO. And my research also validated that. The research also shows that orthotists are really good at making AFOs, all the technical aspects. But the technical aspects of the AFO doesn't match the real life functioning of the person with a stroke. And that's where we have to blend the two together. And really how that happens is communication. And we all should be meeting as a team. For the last AFO that was a custom one that I did, I was present with the orthotist, the person, the young adult, and both of the parents. And we had this discussion about where that person is in life, what they wanted to do, and how we could make that AFO function for them the best way possible. So, what can be done to change AFO fit and function? Communication amongst all the providers, PT, OT, the individual with stroke, and the orthotist. So I look to the OT practitioner to answer these questions. And if you don't have an OT present on your team, the physical therapist should be doing this. What is your life role? What is it that you like to do? What makes you tick? What do you value? All right. And then we have to shape the AFO around that because the AFO that I make for the new mom who had her stroke during childbirth is going to be different for the AFO that I make for the gentleman who wants to duck hunt and the AFO has to fit in his hunting boot. I always ask, do you regularly exercise or engage in some type of physical activity prior to the stroke? Because we know this is about a behavioral change. And you just can't exercise to fix the stroke problem during the rehab. You're going to rehab. We need to change the thought that we need to teach you to exercise and engage in a physical activity for the lifetime for better health, just not for the rehab period. And I think that needs to be a big shift. So that's why I ask people whether they exercise or engaged in a physical activity before, because then I can get them back to doing those type of activities and I know it'll be long lasting. And then I tell everyone to bring their shoe that they normally wear to the PT session, the OT session, with or without the orthotist. Why? Because I can take out the liner in the shoe and I can see their weight bearing pattern. The bottom of the AFO should look like the bottom of their foot. So if you see this AFO, it has a whole bunch of curves. All right. If you look at this one, it has a whole bunch of curves. It looks like the bottom of their foot. It's not rigid and it's not flat. So the outer sole of the shoe will tell you how they weight bear. Are they a supinator where their arch is high and they're weight bearing on the lateral part of their foot, or they're overpronator and they're weight bearing on the medial or inside of their foot? So that tells you a lot about the shoe. And then it tells you a lot about the type of shoe that they need to get to accommodate what's coming up next is that their ankle range of motion. And I also tell them to show me how you put your shoe on because there's a lot of things I can add to the AFO. If you only have one arm working and you can use your finger, loop it through and help put the AFO on. There are things that I can do depending on how you put your shoes on to make it easier for you. And a lot of us don't think of that. We just say you have to get somebody to help you. How about let's change the AFO so that you can be independent in putting it on? So remember I said previously that you have to get a shoe with a heel that may have to accommodate your ankle range of motion. Most women wear a sandal or a heeled shoe anyway. Your sneakers are heeled, but a lot of people don't notice that they're a little high in the back and narrow at the front, or they can be one solid sole that's the same height in the front and the back. And that makes a difference if you don't have good flexibility of your ankle joint. So I tell all of the physical therapists that they should measure the ankle in three positions: laying down on your back, sitting up, and standing. Why? Because you have this vestibular system in your head, and the tone and the response to where your head is in space compared to your body changes the muscle tone. Your muscles may be tight, they may be loose, but when your ankle doesn't move, it may just be more than tight muscles. It may be that the tendons and the ligaments that surround your joint have become stiffed and they can't move because you couldn't move your ankle up and down. And sometimes you don't have to actively move it up and down. Sometimes you need to pull your ankle back when you're sitting by loosening the strap on that AFO and put weight on it as you stand up. We always tell them to push up with your strong arm. They're leaning to the strong side. They're not putting any weight through their ankle. And just putting weight through the ankle keeps it stretched, keeps the ligaments and the tendons stretched. It helps to lengthen some of those muscles. So I tell them to measure the ankle in three different positions and then assess the muscle for how it functions in a shortened position, in a lengthened position, and then in a steady state position, meaning the muscle does not move. You should also be exercising the muscles in those three lengths: shortening, lengthening, and isometric or steady state. Then what should we consider with the orthotist? Now, remember, the orthotist will see you once or twice, and then your physical therapist spends the most time with you. So the physical therapist should be doing a detailed examination and sharing that information with the orthotist because you change over time. This is the same AFO on one person that changed over time. Notice how high it was. And I had all of these what I call sidebars on the AFO. That's because he had difficulty rotating his leg. When you move your knee towards your toes, your leg rotates. And he would just fall in at the knee. His leg would come in. And so he needed some protection for that. But then I started training him and strengthening him a different way. He didn't need all of that. He didn't need the forefoot or the seat of his AFO to be so long, so we trimmed it at the toes. As he got stronger, his AFO got shorter. I need the calf muscle to work. And the calf muscle can't work if it's tied in with a rigid strap and it doesn't have a space in the back to expand and contract. Notice the diagonal of his strap across his foot. I allowed for movement. All right. And if you notice in the last picture, he's a tall cup of water, but he's able to stand up without using his hands. And you can see all the nice little ridges in his muscles in the front, the side, and the back of his leg. If I had kept him in a tall AFO with a rigid strap, he would not have been able to improve like that. Remember, the AFO is initially made for foot, leg, and ankle stability so that you can walk, not for making changes over time. So if you're doing the same exercises and not changing the way you do the exercises, chances are you may not get better over time if all of those motor and sensory neurons are intact and have the ability to change. The insurance company doesn't always reimburse for the time, the effort it's going to take for the AFO to change over time. So, may I suggest that you ask your physical therapist to use more than one outcome measure to not just measure your physical function, but measure how the AFO is fitting and functioning for you. In April, I had a paper published about the use of outcome measures from physical therapists And were they giving that information to the insurance companies to justify the use of the AFO and the need to change it, how it's working? And you'd be surprised, there is not one comprehensive outcome measure that does all the things that we need to justify the use of and the modification of an AFO. For individuals who have a prosthesis, they have a wonderful outcome measure that's used by insurance companies for reimbursement. So, those are just three examples of what can be done to modify the AFO so that it fits better for you, it functions better for you, so that you can function in society. I have many more recommendations in my book. Brace yourself. Everything you need to know about AFOs after stroke. I think what's most important is I have definitions and pictures, everything related to a stroke and the muscles of the leg and the foot, shoes, and AFOs. I define what foot drop is. All right. And then I explain why you need the AFO and what it should and should not do. I think what's most important is I have an entire chapter in there explaining what the physical therapist should do in terms of examining you for an AFO and what the orthotist should do. But most importantly, I empower you to ask questions to the physical therapist and the orthotist. So there are two chapters in there of what you should be asking about your AFO. And last, hold you accountable. What should you be doing when you get the AFO? And then at the end, I have some of my clinical pearls of wisdom about what you should do in the future with your AFO. And I would like to say, not everybody can wean out of an AFO, but I am happy based on the therapy interventions that I do and the good health care that's received by the individual early after stroke. A lot of my clients do wean from their AFO. They don't have to wear them. But these people were consistent and diligent with an exercise program. They engaged in physical activity. All right. They were the doers and the want to becomers and those type of folks. No matter if they had an impairment that didn't get better over time. So, in the end, if we had to look at everything, I think the biggest issue is communication. And I need you all to talk to achieve the best walk. That book will help empower you to say the things that you need to say to get your best fitting AFO in order for you to function. We as healthcare providers may be experts in our professions, but you're the expert in your lived experience. And we need to listen to you and take what you say and then modify the ankle foot orthosis so that you can move better, live better, experience life to the fullest. So, thank you for attending. If you have any questions after listening and reviewing this PowerPoint, please email me. And that's the information there. I do have a website, and this is where you can get the book if you're interested. I just want to end with acknowledging the entities that provided financial support for my research. And if there are references here, if you would like to look them up. Thank you for listening to this presentation. I'm Dr. Jennifaye Brown. Take care. Bye-bye.